Hello and happy Teach Me Tuesday. We survived Monday, so now we are on to Tuesday. Today, as promised last week, we are going to review 7 more medications. I wanted to call them less common. I was trying to come up with a catchy title and it didn't quite work out, but let's go with uncommon medications used in the NICU. I hesitated to use the word uncommon because they're kind of common. There's probably like a baby on one of each of these medications in your NICU at a time, depending on the size and level of your NICU. But I think you get my point. Things we don't necessarily use every day. Too long of a title. Let's just kind of think about our medications for a minute here, right? We give a lot of medications in the NICU. Some of them feel very common and routine and things that we're kind of used to doing every day. But the ones that we don't use as often, we have to pause and ask ourselves, hey, what's the mechanism of action here? What are we trying to solve? What are these medications compatible with? What line can I run them in if I'm giving them IV? Do I need a separate line if I'm giving them IV? What is the medication they can be mixed with? Are we using them off-label? Are we using them in kind of a way where we know that they are beneficial, but they might also have some drawbacks? In all those situations, it's really important to be having conversations with your entire care team, which includes your providers and your parents, to make sure that everybody kind of understands the risks and benefits of what's going on with these medications that are less common. Let's talk about steroids, not the bodybuilding kind. Although sometimes we see babies go into roid rage after we give them their steroids. But if we think about our Decadron or hydrocortisone or any of those medications that we are using usually for one of two reasons. And right now we're talking about more of what we're doing to help with our babies that have bronchopulmonary dysplasia or chronic lung disease, those kind of vent-dependent babies. How can we help get them off of their ventilators? How can we improve their oxygenation? So we can give them steroids such as Decadron or hydrocortisone to reduce inflammation, specifically in the pulmonary structures, so that we can then allow for growth and repair so that the alveoli and the bronchioles can have a time where they're not such in a state of stress and they can get rid of some of that inflammation and allow for healthy growth. We do also give steroids, of course, especially hydrocortisone, for blood pressure maintenance, urine output, those other things. But the primary reason that you're going to see steroids used in a NICU is going to be for chronic lung disease or bronchopulmonary dysplasia. How can we help these babies really recover in their pulmonary system? Something really to keep in mind is there are a lot of side effects. So as you can kind of see here is it can decrease the response to pain, it can increase your blood sugar, and it can also increase your blood pressure. Another thing that we do also consider when giving these medications is some of our neurodevelopmental long-term outcomes and making sure that we are using them in a situation where kind of we have tried other mechanisms to get our babies off the ventilator or to help reduce some of their ventilation or ventilatory settings, just to make sure that this is the best potential outcome for them and what we really need to do to help them not be vent dependent. So those are fun steroids, and sometimes as we're weaning them, the babies do get angry. I was recently on steroids when I was sick, and I did not like it, and I couldn't sleep. So it kind of made me think about the babies and what are they experiencing when they are on steroids. So sildenafil is a medication that we give to premature babies. It's a very weird thing to be giving at first. As we know, this is another name for Viagra. But really all that sildenafil is it does allow blood vessels to relax. So usually we are not giving sildenafil alone for the treatment of pulmonary hypertension, but we give it as adjunct therapy when babies are also on inhaled nitric oxide. So it does act directly on the pulmonary vasculature, helping with vasodilation and just that relaxation for better gas exchange. So these are babies with severe pulmonary hypertension that really have this, remember, that clogging of the circuit between the heart and the lungs. So how can we help them relax to have better oxygenation? So that is what we would be using sildenafil for in the NICU. Amphotericin B. So we recently, I guess it was about a year ago, I guess that isn't that recent, had a baby with a fungal infection in their skin. As we know, our babies are very susceptible, especially our extremely low birth weight, our extremely premature babies with their very fragile skin and increased permeability, and they just don't have the best defense mechanisms, are at risk for these fungal infections. And so we had a baby with a fungal infection on their skin. It was specifically on his back, and we were giving him amphotericin B. So this is an antifungal, and it is rough on the babies, and sometimes we actually have seen some issues with our PICC lines if we're not pausing other medications that are going through at the same time. So primarily we are only using it for systemic fungal infections, neonatal sepsis, or fungal meningitis, kind of like those big things that happen with fungal infections. This is not something we would give prophylactically. This is when we know the baby has a known fungal infection and we really want to get at it and attack it strongly. Amphotericin B is going to be our medication that we use in these situations. IVIG, I swear every time I have to use this, I'm like, okay, is this go on our blood transfusion record? But we have to remember on IVIG is it is a blood component that really is just full of antibodies. So typically we have our IVIG, and that crosses our into the baby from the mom. We have all these lovely our immunoglobulins that the baby's getting during passive immunity. But sometimes, especially for our babies that are born with any sort of hemolytic newborn disease, whether that's hyperbilirubinemia from the mom and baby incompatibilities, that's going to be probably the primary reason you're seeing the use of IVIG, and that is so that we can really boost up the antibodies to be able to protect the baby from the breakdown of those red blood cells that are happening kind of like when there's this mismatch, right? And the mom cells are attacking the baby cells. So we don't want that to be happening, because every single time then we're having these red blood cells break apart and increasing our bilirubin. We also use IVIG, I would say for next most common reason would be for immune deficiencies. So if you think about if you've ever been called because your ANC is really low, if you have an ANC in the points or 0 or 1, very low ANCs, those babies actually often will be put on almost like reverse isolation, where they are getting isolated from us. So we need to wear a gown and mask and gloves to make sure that there's no chance that we would give them any sort of bacteria or anything, a virus, anything, because of how low their ANC is. They may give IVIG to help boost up some of those immunoproperties. So those would be probably the primary reasons when you have a baby with severe hyperbilirubinemia, where their bilirubin is 16, 18, 20 in those first 12 hours of life. This is often given prior to considering an exchange transfusion, in addition, of course, to fluid hydration and phototherapy. But this would be one of our primary medications that would be given for those babies with severe hyperbilirubinemia. Acyclovir. Anytime a baby is being admitted for a rule out of herpes, and we're going to be getting an IV going, I'm like, okay, we have to get 2 IVs going, because acyclovir, maybe uncommon knowledge, maybe common knowledge, must run in its own IV, and it runs over an hour. So if you have a baby who is getting dextrose containing solutions for their blood sugar, maybe they're not eating, they're small, they're in respiratory support, whatever it might be, pausing their IV for an entire hour plus a flush is just going to be way too long. So they end up with 2 IVs, one to run their acyclovir on, and then one to run any of their other fluids or medications. So just remembering that anytime they come in. But acyclovir is the most common medication we use to treat herpes. We do give it prophylactically if the mom had a active infection during delivery. We want to make sure that we're giving it even before any of our swabs are back. This also requires many swabs and cultures to be sent, including a spinal tap, to make sure the baby doesn't have herpes meningitis. So this medication, acyclovir, is kind of one of those big guys that we use to help with treat this, even if it's prophylactically or if the baby has come back positive with their herpes virus swabs. So ganciclovir, whenever I think of ganciclovir, I think of the chemo buckets for the trash cans because of the special gloves we have to wear when handling any body fluids, and the way we have to protect ourselves that are taking care of the babies. So it is an antiviral medication primarily used to treat CMV. Recently, I was participating in a CMV call about how can we increase our screening here in the state of Missouri to make sure that we are getting babies that need to be treated for CMV caught early, which can be a little bit easier in the mom-baby newborn world, a little bit harder in the NICU world. But we were talking about if babies have referred on their hearing screen. So maybe they got retested and they failed their hearing screen twice. So that hearing loss can be one of their signs. If that's caught in the first 21 days, they can receive this medication if prescribed that can help reduce their risk of those long-term effects, such as developmental delays and vision problems and worse outcomes for their hearing. So that is what ganciclovir would be used for. It is an antiviral. If your baby had another kind of random virus, it's something that could be used for that. But primarily in the NICU, we are going to see it to treat CMV. And CMV can be tested in urine or a cheek swab. We primarily use the urine route by just putting a bag on. It's just a clean catch and seeing if the baby has it there. And then if we treat them with ganciclovir, it is a kind of a bigger medication with some chemo properties in it. So we treat it with a chemo drug. So if you are using that, see if that is what your institution's policy is regarding the use of ganciclovir. So PGE probably could have gone first on this set. It's probably the more uncommon medication that we use. Primarily, we're using PGE when we know a baby has a critical congenital heart defect, CCHD. So for these babies where we want to keep the ductus arteriosus open, we are going to use PGE, which sometimes we want to start before the baby even gets there, have it primed, ready to go, know they're going to a delivery. If you have some sort of fetal care team or a way of knowing when you are going to have a heart baby or any other of your anomalies born, this is something that's important to have at the bedside right away, to have it primed and ready to go through your line. It works by relaxing the smooth muscle in the blood vessels. So whenever I think about this with a PDA closing, I always think of like the two sides like coming together and closing like a door. And I think of when you're using PGE to keep your PDA open, it's like, oh, let's be loose and free and not touch each other and not close. That's just like the visual I have in my brain. So we're trying to keep that duct open so that we can have blood flow through there, so that we can have mixing of the blood. So down here in this picture, if this baby had transposition and the aorta was coming off of the right side of the heart instead of the left side of the heart, we would want to keep that PDA open so we can continue to have mixing both of getting the unoxygenated blood into the lungs and getting the oxygenated blood out to the baby. So I was taught some point in my career is whatever color your aorta is what color the baby is going to be. So in this situation with transposition, that's when your two great vessels are your pulmonary artery and your aorta are swapped. So if your aorta was coming off the right side of the heart, it would be blue. So your baby would be blue. So the only way we're going to get them oxygenated blood is by something like the PDA. So we want to make sure that we have that PDA staying open and maintaining that it's open and increasing its diameter. So that's when we would use PGE or prostaglandin E1. So in all of these medications, it's still so important, right, to know our correct med, our route, and our dose, understanding our mechanism of action. For our uncommon medications, it's really important that we understand why we're using it and the risks it may carry. I think about this a lot with steroids and kind of, there was this big push for Decadron at the beginning of my career, which is coming up on 20 years. And then we went away from using Decadron and dexamethasone, and now we use hydrocortisone maybe a little bit more. But they do have some poor neurodevelopmental outcomes. But the question at that time is, if it's this or we can't get the baby off 100%, then maybe we need to give it. Same thing with using sildenafil to supplement INO. If your INO isn't working, should we be giving the sildenafil? Can we give the sildenafil without the INO for our persistent pulmonary hypertension? These are the things that we really have to think about, is like, what are the risks going on here? And how can we help our parents understand and empower them to know what their baby is receiving and why their baby is receiving it? So please come back next Tuesday for another edition of Teach Me Tuesday, and be sure to check out all of the videos on YouTube. And please comment if you would like to hear anything specifically. Have a great Tuesday.